Hi, you've reached the voicemail of Hannah Brett with Connect Call. Just leave a message and I'll get back to you as soon as I can. Thanks.
1 for more options.
Hey, Hannah. We met through a friend of ours recently, and I think I told you I'm very concerned about my sister. She's been struggling with depression for a very long time, and she self-medicated for many years, but then she got sober. She's been in treatment a couple times for the depression, inpatient, unfortunately, a couple times, and they just keep trying to change the antidepressants. They tried ECT, nothing's really working. We're looking at TMS next, but I don't know. I was wondering if you had any other options or recommendations. If you can get back to me, that'd be great. Thank you. Hey, Hannah, we met through a friend.
Hi, this is Hannah Brett, and on our latest episode of Connect Call, well, first of all, I like to say that I do not have a clinical background, but I do have a PhD for picking up the phone with families in crisis. And after 20 years of kind of doing this, again, I wanted to do an episode on a topic that I think is very relevant and a lot of people have questions about, and there's a lot of myths and false information out there. Typically, as you all know, I talk about a caller on these episodes, but today I'm going to actually talk about myself and my own journey with my mental health and why this subject matter is really important to discuss. Well, first, let me introduce, I've got Jonathan Lowe as our guest today. He is, I used to work with him at a treatment center. Jonathan, you were like our executive director, right?
Clinical services, yeah.
Yes. And we used to call him J-Lo, and he is the shit. And I also wanted to bring him on for this episode because in my experience of the 20 years I've been out there and listening to different providers and experts, Jonathan, you have been probably my best teacher. Like, you really explain things to people like myself that don't have a clinical background probably better than anybody I've ever worked with. So I used to hang on his words when he spoke and miss you dearly working with you. But so the subject matter we're going to talk about is, I got sober 23 years ago. And with that, it was very black and white. You know, this is sobriety. These are the 12 steps, blah, 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 blah. And back in the day, even in some of the old school of AA, which isn't the case anymore, you know, they were antidepressants. You know, they were just like not wanting you on any medication. And so kind of with my journey is, you know, I went to treatment, got sober, more meetings. I think I was on like one antidepressant that was going to treat my depression and anxiety. And kind of what I've learned over these years is all that addiction really is mental health and trauma untreated. So if you're not treating that mental health piece, you're just going to self-medicate. And about 8 years or 10 years into my sobriety, my depression took such a tank. Like I went down real fast. And I had the kind of depression where I think I'm going to say now I'm fortunate because it wasn't a functional depression. It was a depression that took me out. I couldn't bathe. I couldn't sleep. I was in darkness, suicidal ideation. And, you know, for the longest time, I was just trying to figure out where this was coming from. You know, was this something from my reproductive cycle, you know, or like, was this something trauma untreated that I wasn't discussing? But at the end of the day, I was running in this hamster wheel of trying all different types of antidepressants. I also knew at this time to ask for help. And I went for like 3 weeks to a treatment center to get assessed with my mental health. Didn't really work. It wasn't enough time. And also, I kept having, we'll talk about that in another episode, but when you do insurance-driven treatment, sometimes you have a bunch of doctors, so you don't have one person kind of attending to you. So finally, it got so bad that I was like, all right, well, I want to go to the best in the country. And at the time, I thought McLean Hospital, which is the teaching hospital for Harvard, the guy who ran the addiction unit over there was this guy named Rocco Iannucci. And I said, whatever I need to do to get in front of Rocco, I want to work with him and see if he can help me, maybe put me on a different medication and all that. I spent 30 days with this amazing doctor. And after trying a couple more different antidepressants, he came to me and said, okay, we have two choices right now, Hannah. You're kind of treatment resistant, and we'll talk more about that. So I'm going to either recommend, and we will talk about this on another episode, why I wasn't a good candidate for TMS at the time, but he recommended either ECT, which is electroshock therapy, or he said, recently we've been doing more and more studies. This was like 10 years ago, on the ketamine infusions. And we think you'd be a great candidate to do a ketamine infusion. And like a lot of people out there who weren't informed on ketamine, I immediately went to this place of, no, that's a party drug. I don't want to go into a K-hole. You know what I mean? And I was like, oh no, I'm sober. Give me the ECT. I'd love to do electroshock therapy. And unfortunately, I wasn't a good candidate for ECT. Didn't do anything for me. For some people, it really works. But for me, I just lost 2 years of my memory. And I circled back to Rocco after a year or two and said, okay, I'm desperate. I'll do anything. Just tell me who to go to, who is the best provider to be assessed to get one of these infusions. And I felt, and I wanted to have Jonathan on this episode and really discuss this topic, because in the work that I do today, there's just so much, like I said, misinformation on these treatments. And a big part of why I'm doing this podcast is I don't know everything on everything, but I do know, because of my journey and watching other people, but more importantly, just dealing with myself, I've tried everything. And I have seen how effective these infusions have been for myself and others. And so I thought it was the responsible thing to do to put an episode out there to really educate people really on what ketamine is, how it's used. And so, like I said, you are the best teacher that I've had in explaining things. And I know you do a lot of work today, and you're working Tahoe in California with ketamine and Spravato, the nose spray. So I guess let's just start from the beginning and keep it real basic. Like, can you explain really what originally these ketamine treatments are and how they're used to treat for depression, and how, more importantly, they are different than an antidepressant that we are trying?
Yeah. So great to be on. It's good to see your face. Thanks for having me. Yeah. Hi, by the way. So traditionally, we have been treating depression with medications like MAOIs, TCAs, SSRIs, SNRIs that really focus typically on like one transmitter, one small part of the brain. It's focusing on serotonin, right? It's focusing on dopamine. It's focusing on norepinephrine. And these aren't medications. When people take them, they quote unquote feel happy. And we'll get in, maybe talk about that a little bit more, and where ketamine might pose some difficulties in terms of the research and studies and what we see with it. Where I think of like, medications like, I don't know, benzodiazepines like Xanax or Ativan, other drugs like alcohol, stimulant medications. These are medications, when given to somebody, they can elicit a feeling. So if I were giving somebody with depression, let's say, one of these drugs and said this was an antidepressant, they would maybe have this feeling of this sense of like happiness, where we're not truly treating the depression, right? We're just causing this shift in this experience. Going back to what you were saying about trauma, untreated depression, untreated mental health issues leading to substance abuse. I mean, that's 99% of the time when I'm working with patients who struggle with substance use. They're just looking not to feel like shit, and who wouldn't want that experience, right? And if there are these medications that aren't treating the depression, but helping us to not feel depressed in the moment or have that cognitive shift, it's understandable why people would seek those out. Whereas our traditional antidepressants, that take maybe weeks, right, to start functioning, really have been leaving a huge part of the population just undertreated or not treated at all. So ketamine is interesting. Psychedelics in general are interesting. So when we use the term psychedelics, I'll use like a broad umbrella, right? And the broad umbrella might, it has maybe three basic paths. We have hallucinogens like LSD, psilocybin, or what some people call magic mushrooms. We have empathics like MDMA, or what people call ecstasy. And then we have dissociatives. And dissociatives is where ketamine and S-ketamine land. And ketamine was really the child of PCP. PCP was a drug that was meant to be a field analgesic. We needed something to give outside of the operating room, outside the medical equipment to keep respiratory rates up. We needed something that wasn't going to depress the breathing so much, but that we could use for pain for procedures. And PCP worked really well for some, right? The problem with PCP was there was a large portion of the human population being treated that would have this like very aggressive response to it. We still use PCP to this day in like veterinary medicine, especially on big cats or big animals, right? Like you can give some PCP to maybe a big gorilla and they'll stare off into the distance while you stitch up a small wound, right? Without having to, put them under general anesthesia. But PCP was really not a great medication for what we wanted it to be, right?
Right.
And so 1960s, we have then the child of PCP, which is ketamine. And ketamine worked and is still a fabulous medication for that purpose and still FDA approved for that reason. Decades later, we see some anesthesiologists really start to take an interest in this medication and maybe some effects that they didn't expect.
Right.
For patients who struggled with depression receiving ketamine for procedures, depression was going down. And so it was this question of, well, what could this be about, right? Why is this helping these patients with depression, and not just in the moment, but lasting effects with depression? And what it comes down to is a couple of things. One, when we go back to the traditional antidepressant medications and their focus, the reason why these antidepressants potentially may take weeks to work, right? We typically hear this like 4 to 6 week mark.
To see the shift, to feel it. Yeah.
See the shift, to feel it. And that's, probably because there's this downstream effect on what are called glutamate receptors, or these neurobiological changes that take place that have to do with more than just blocking the reuptake of serotonin, blocking the reuptake of norepinephrine. Because if it was just about serotonin and norepinephrine blockade or dopamine blockade, then, and theoretically, we should start seeing results in a couple of days after taking an antidepressant. But we know that for so many patients, that's not true. Not to say it, I mean, that does happen from time to time. I'll have these responders where I prescribe Zoloft, and in a few days they start feeling better, which is great, and maybe tells me something about serotonin's involvement in that process. They're lucky, right? But for most patients, that's just not the case. And what the big difference for ketamine and S-ketamine is this potentiation of what's called glutamate. Now, glutamate is the number one excitatory, reparative, restorative neurotransmitter in our brain. Think of it like Miracle-Gro for the brain.
Okay.
It's very fast acting.
Right.
And that, plus a couple of other pieces is probably really where we're getting this rapid antidepressant effect from.
Right.
That, and I will say again, the psychedelic effect, right? Or that shift in consciousness effect that is very different from taking traditional antidepressants,
right?
That can help clear symptoms faster because you're having a very different experience and relationship with these medications than you've had with the Prozacs of the world, or the Zolofts of the world, or the Effexors of the world. So that's where it really sets itself apart, is just this kind of Miracle-Gro process for your neurotransmitters, repairing connections in the brain very rapidly, strengthening dendrites and axons, like basically just strengthening your neurons, along with that speeding up the connection and repairing those broken connections that we often see when we're working with patients who have depression.
Can I ask a question? Because one thing that I thought, and I'll tell you about my experience a little bit with the infusion, everyone's different, right? And originally it was given to me, or they were going to try it on me, because I was having suicidal ideation, and because it was such a rapid change in hopefully feeling better, right? And so where I thought it was effective for me was, and tell me if this actually, so when doctors give out antidepressants, and I used to be a med sales rep and pharma rep, and what we would like to see is, sometimes it's Russian roulette. I mean, now we have GeneSight where you can swab the mouth and hopefully get a class of drugs that work for you. But typically when you're giving an antidepressant to somebody, you're going based on, okay, well, Zoloft has done well with all my patients, so I'm going to give you Zoloft, right? So while I was on my sixth antidepressant they were trying on me, and while I was waiting for that shift for 4 to 6 weeks, I was really depressed. And so where the infusions help me is for the meantime to get me kind of okay as they're trying out a new med. But here's the confusion is, so there's a cycle, I think, of 6 weeks. I was on my second one, and I remember for myself waking up the next day, and that shift that doctors talk about with the antidepressant, I think I felt with the infusion, someone just turned my brain on. I remember distinctly waking up, and someone said, "How did it make you feel?" Afterwards, and I said, 2 days later, I woke up and I was all right, I want to make a healthy breakfast for myself. I want to go work out. I actually want to put makeup on today. It wasn't I woke up and I was yay, I'm so happy. But I felt oh, there's Hannah. She just came back. It was they just turned that light bulb on. And that's what was so amazing and still is for me. My question is, if you're doing that the way I was doing it, how do you know if that antidepressant is working or if it's just the infusions?
You mean by doing them together?
Kind of, yeah. Because some people do that while they're trying out
Yeah.
a new antidepressant just to get
Yeah.
them through.
Yeah, well, your story, of course, is the story of so many patients. We have this wonderful study, this meta-analysis called STAR-D, that has been reinterpreted since I think 2020, 2023. Also, we kind of re-explored. The STAR-D was a real important guide in psychiatry on how we prescribe antidepressants.
Right.
And at first, the picture was a lot brighter than the picture is now with the updated interpretation of this study. Meaning that if I have a patient who has depression and I'm following kind of gold standard treatments, outpatient, looking for something that's accessible for them, I meet Jonathan for the first time and I diagnose him with major depressive disorder. And I prescribe him any number of antidepressants based on maybe poor man's genetics, like his mom took Effexor and did really well, so maybe I take Effexor, or maybe I'm looking more often than not, I might be looking to minimize certain side effects that would just be a non-starter for that patient, and maybe that's helping me to choose the medication pathway. That first medication, you can flip a coin and actually the odds are a little bit less than 50-50 that is actually going to work for them. And by work, I mean having a response. A response is seeing a 50% reduction in whatever tool that we're using, whether it's a PHQ or a MADRS, something that the patient reports or during clinical interview, we kind of mark the symptoms of depression. We're looking for a 50% reduction in those symptoms. That would be a response. Now, let's say that first antidepressant, the patient takes it for the 9 to 12 weeks, which would be ideal, but a lot of people don't even make it that long if there's negative side effects. But let's say they take it for that amount of time and we're not seeing that response. And we're certainly not getting into remission, which is a step above response, right? Where the symptoms are clearing to the point where I wouldn't be able to diagnose this person with a depressive disorder if I didn't know that they were on medication. Say that they were in the wrong office.
Right.
So if I try that second one, right, that first one was a failure. Now I'm going to drop the odds down. There's diminishing returns. And this is what the STAR-D data shows. It's really important. If I try that second antidepressant, I'm going to drop it down probably somewhere in the low 30s or mid 20s, right? That they're, going to take this every day. And here's the chance that we're going to have a response.
Right.
If I have to try a third, we're probably talking about 12%, right? Really low odds. And to hear that from a medical provider, and probably not hearing this from your medical provider saying, hey, Jonathan, I'm sorry, these first two didn't work for whatever reason. If you try this third option and you take this every day, I will give you a 12% chance that you're going to feel better. As patients, understandably, we want to, like, what do you have? What else do you have? And that's where these other treatments, like you mentioned, ECT, TMS, other medications that we've used in adjuncting, whether it's low-dose antipsychotics like Abilify or lithium is a great adjunctive antidepressant as well, become important, but those are also not right for everybody. So when the STAR-D data first came out, the rule of thumb was basically from that is about if we work this algorithm, about 2/3 of patients will get responses to their antidepressants. With the updated interpretation of these studies, it's 1/3, right? So it's not to say like 1/3 of patients by following this algorithm are going to get these achieve these goals that we're looking for. It's just not great. And we have better medicines out there, arguably. It's just finding the right medicine for the right patient or the right treatment for the right patient. And when, with ketamine and S-ketamine and the exploration of other psychedelic treatments that are on the verge of being approved for these types of disorders, the benefit is, one is a radical and a radically different experience than you've had with your oral antidepressants, right?
Can I interrupt? And we're going to go rogue on the questions here.
I love it.
So let me know everything you're saying is brilliant, but when do you know when you're treating a patient, right? You're going to give them one antidepressant. Maybe it's not working. They're suffering and struggling. And I got to tell you, someone who struggles with depression and the way I did, every day felt like a year. When do you say, you know what? It's time to try some, an infusion, or what we're going to talk about the Spravato, which is the nose spray of like a ketamine. I'm going to say the word wrong, but treatment. Like, when do you know, like, this is a treatment resistant person, or this is somebody that would be a good candidate?
So treatment resistant, there's no one definition, right? Every insurance company has their own definition for what they consider treatment resistant, right? The bottom line across all studies, all use of the language with insurance companies is a trial and failure of at least 2 antidepressants. Now, some insurance companies will say, no, it actually needs to be 3, or it needs to be 2 of different types, or it needs to be an SSRI with an SNRI, or an SSRI with an adjunctive antipsychotic at an appropriate dose for an appropriate amount of time. That can be different. Where I start to think about these interventions is after that second trial. Now, in many of the studies that were done with ketamine and S-ketamine, patients were more likely to respond to the treatment if they had tried and failed multiple antidepressants. So 2, 3 antidepressants, rather than the patient who maybe only tried and failed 1. So for me, what it comes down to is what makes sense for the patient. We can talk about like a good patient profile, like who's a good candidate for this and maybe who's not.
That will be a question. Thank you.
Okay, good. So because again, if I'm being prescribed another pill, right, and I'm already coming from a place where like this stuff's not working, I'm already coming from a place of kind of losing hope, right?
Preach.
And yeah, and where I like these alternative treatments, whether it's TMS or ECT or ketamine or S-ketamine or other psychedelic treatments, is that it radically changes your relationship with how you're engaging with your treatment. It's a very different experience than taking a pill every day.
It is.
And I think that there's a lot of benefit to that when I have kind of been in these bad relationships with medicines over and over again, to really shift that relationship in a meaningful way. And then there's this whole other piece of these treatments when it comes to ketamine and S-ketamine and other psychedelic treatments, where we see this boundlessness, right? This shift in cognition that is typically very, very positive, where we feel much more not just connected to ourselves, but connected to something bigger than us. Because
Mhm.
depression is a very lonely place to be, right? We could be in a group therapy treatment with 10 other people with depression, and we all feel utterly alone.
Right.
And to have medicines that not only treat the depression on a neurobiological level, right, and that neurochemistry, but
Right.
also have this amazing ability for many patients to help them just feel connected to their life again. Like you said, getting up and like
Oh,
wanting to make myself a healthy breakfast,
yeah.
wanting just to engage. It's so important. And these treatments offer a very, really fast and effective pathway to that.
I think, something I definitely want to talk about now is because it's sad, but, as a treatment specialist, helper, as you may call, the shame I felt for some reason of me just struggling with my mental health. I mean, now today I know like it makes me a better me, makes me better at my job, makes me better for helping people because I have walked that walk with these people. I know when people are struggling what that feels like. I think what was frustrating and still is, and it's still very rampant out there, is in our industry or those who are sober, right? Or in AA, and I've come across this shame of and misinformation of what the treatments are. So I remember when um, we were recommending somebody at my old job for an infusion. Some of my colleagues were like, "Oh, what? They're going to go into a K-hole," or like, "Hey, why don't we just set up people just to fucking trip?" And I'm like, "You're so not informed. You so have no idea what you're talking about." I think also, with all due respect, just like propofol with Michael Jackson, we still use propofol, although that was his baby. He called it his milk, and he was addicted to it, and he. For those of you who don't know what propofol is, it's a really nice nighttime kind of not anesthesia, but it kind of puts you out for a baby nap and brings you back up when you're doing like minor surgeries. But that was addictive for him. And just like that, we got these stories about Matthew Perry, and I remember when they came out about him, unfortunately he died, and a part of what they found in his system was ketamine. I knew that he had vials and vials prescribed to him by a doctor whose assistant was just shooting up, right? I knew he was, we all knew he was abusing it. But I think at the time, what was just so like frustrating as someone who sees the benefits of these infusions is it kind of gave ketamine a really bad name for a second. And so, or it used to be the horse tranquilizer. So I guess, like, can you separate some myths out there from some facts? Because I feel like people don't really like the myths out there are that it's just going to be addictive, you know?
Right.
And I
Right.
will say, as somebody who has that brain, when I'm going in for my infusion, when I leave, it does not turn on that let's go more, let's do more. It really doesn't for me.
Right. And yeah, no, it's good. And that's what so many patients report. And in fact, newer forms of ketamine that are on the cusp of being approved for medical use by the FDA are focused purely on addictive disorders. We know that these types of medicines have shown for a
Really?
long time a
Right.
lot of benefit for rapid response in helping with addiction. Now we have studies, then we have real world, kind of studies, right, where we track populations over time once the medication is out, kind of being used in the
Hmm.
real world. And there's some differences between those. But when it comes down to the abuse potential, right, you can abuse a whole lot of things. When the
Whole lot
abuse
of
gets
things.
a
I
whole
take
lot of things,
gabapentin. I can take the bottle and go crazy probably,
we
but
can abuse, yeah, in a grocery store or in our home,
right,
under our kitchen, under our sink. There's plenty of things around that can be, abused when we're using them for purposes that they weren't intended for, right? The
right,
abuse becoming an addiction when the focus on the use of that substance is so high that it's taking precedent over other activities in our daily life.
right.
it's impairing our ability to be a partner, go to work, go to school. It's taking that much of our focus, where now it is an addiction. When it comes to ketamine, the first thing to understand is that the data that we have out there is that ketamine related deaths are extremely, extremely low, right?
Right.
So there was a meta-analysis done in the UK that spanned, I think, like almost a decade, from the late 90s or mid 90s to, I want
Right.
to say, like 2017, where there was 4 deaths attributed to ketamine. Right, and it doesn't, even though ketamine was listed as this maybe the singular drug found in their system, it's still unclear, did the ketamine cause that person to die?
Right.
Because you have to take a lot of ketamine for ketamine to depress your breathing so much, or to cause an event that is so severe that is the thing that makes you pass away, right?
He also had other
And
drugs in his system too.
well, here's the thing, right? Is that most ketamine deaths are attributed to accidents that are related to things that happened while the person was on ketamine, right?
Right.
So when somebody is driving intoxicated from alcohol and dies in a motor vehicle accident, we don't
Right.
say that they died because they
Of
had an
alcohol.
alcohol overdose, right? Alcohol was involved and a huge piece of that, right?
Right.
And the same thing with, like, I think of Matthew Perry,
He
and
was drowning.
unfortunately, he was left alone
Right.
on a variety of substances, including ketamine,
Right.
and drowned,
Right.
right? And he was put in a really, really unsafe environment, right?
Right.
With that,
With a
even
high
if it's
dose of a lot of things.
with a
Right.
high dose. So when we're talking about the clinical use, there is no research out there to show that there is an addictive or dependency quality to the use of ketamine when used appropriately in these clinical settings.
Right.
Ketamine abuse usually involves a use of a gram or more, right, of ketamine daily, right, for our ketamine abusers. And it's all about access.
That's a lot.
So PCP is pretty easy to make, right? I'm not going to give you the recipe, but it is not that difficult to kind of set up shop and make PCP at home. Ketamine is very difficult, right? So the ketamine that we see on the streets, one is that sometimes it's not ketamine. Patients who believe that they have been using ketamine at a party, and we test their urine, we send it off for advanced testing, and it is not ketamine.
Right.
We see higher rates of ketamine abuse in Asia, where we have a lot of the manufacturers of the world's ketamine, because there's there's just more available to them, right? Where
Right.
here in the US, we just don't have it widely available. It's either being diverted from, oh yeah, go ahead.
Well, no, I was going to say, actually, what I saw, and I think you saw too, and that's a whole nother subject, is, and I tried it because I was in the UK and I was stuck, and they were behind and they didn't have the infusions. During COVID, we started this whole influx of, you can go online and be assessed by these doctors. And if you were a
Hmm.
candidate, then you got the trochets, or you
Yeah,
got,
yeah, yeah, yeah.
things sent to you. And trochets it's like a
The
cough drop
trophies, yeah, yeah,
of
yeah, yeah.
ketamine
The
that you would put
lozenges,
under
yeah,
your tongue.
yeah.
To me, I will say it it didn't hold a candle to the infusions, but it really gave access to a lot of people that
Well,
wouldn't
gave
typically.
access to a lot of people, and there are some, I think, dangers into that home style treatment, where we're
Right.
now sending, like you said, lozenges or troches, or even
Trophies.
subcutaneous injections, right,
Right.
of ketamine now,
Really?
to patients in their home. Yeah,
They're sending
absolutely,
injections of ketamine to people in their home?
they are. And I'm not going to say, I mean, for the right patient, for the right circumstance, like,
Correct.
great. I think as long as somebody is getting the help that they need, I think
Right.
that's the most important thing. And it's all about access. But
For me,
for
I was stuck in Europe during COVID. And again, literally, I think there was one doctor in London who was doing the infusions. And just to speak to him was like $1,200. Forget about the infusion. But I needed in that moment, in case of an emergency or I was going down, that I had
yeah,
something, right?
yeah,
But And I think that's also a lead into the next question is, and I do want you to, explain the difference between the infusion and also
Mhm.
the Spravato, which you do.
Yeah.
But before that, here's where there's been a lot of debate. So we both worked at a treatment center where we focused on adolescents and young adults, right? And do you feel, I guess the rules still apply for adolescents and young adults. If they've tried 2 or 3 treatments of antidepressants and it's not working, it's a case by case, right? And I think what I'm seeing in the treatment world, which I think is good, and people are freaking out, but I think it is good, is some programs now are offering those infusions as part of the treatment. And I think for certain people that really struggle with depression, and I say this because, and I do get really defensive now because it's like, unless you've walked in these shoes of wanting to die, like you have no idea. And people like me were so desperate just to feel normal. I didn't want to get high. I didn't want to dissociate. I just wanted me back. And so I was then open. I mean, I would have done ayahuasca. I would have done anything just to feel normal. And part of also why I do this podcast is to talk about, like, there's not one way to recover. There's not one way to give yourself the best life. And so I want to expose our viewers and listeners to all different types of treatments. With that, can you explain, because I do infusions, but some people do the nose spray, which you treat with. Can you explain the difference?
Yeah, so ketamine is a mixture of both what's called S-ketamine and R-ketamine.
Right.
And what we've done, or what Janssen has done, is that they have, so ketamine, like you said, it can be very expensive because it's not FDA approved for any mental health purposes. So when we
Right.
go to these ketamine clinics, whether it's online or in person,
Right.
it's really the what is the market supporting in terms of cost
Right.
and access. And so now we have S-ketamine. The brand name is Spravato, and it
Right.
is only FDA approved for mental health treatment. It's FDA approved for treatment-resistant depression, as we discussed. Like there's different definitions from different insurance companies, and it's also approved for major depressive disorder with acute suicidal ideation.
I
Because
didn't know that.
S-ketamine in its studies is one of only really 3 psychiatric drugs that have shown to help with suicidal ideation. We have S-ketamine, we have lithium, and then we have an antipsychotic called clozapine, but that's a very narrow population that we're
Right.
using that drug for, right, to help with suicidal ideation. And it's as effective as ECT,
I
right?
didn't know
But
this, Jonathan. This is
yeah,
so
yeah,
interesting.
it's good
Go on.
stuff, right?
Yeah.
So S-ketamine basically just takes apart, right? Just like a half of what makes up ketamine.
Right.
When we do this with some drugs, when we kind of split them, we can create drugs that are more quote unquote potent, or maybe have more of an affinity for their mechanism of action, like a higher, stronger mechanism of action.
Right.
So that's what we have found with S-ketamine, is that I can now give 56 or 84 milligrams of the 2 doses intranasally, outpatient. And the beauty of it is it's covered by insurance. So for me,
Yes.
it's not that I prefer one over the other.
Yes,
It's
you're
about
right.
what's right for the patient and what can they access. A lot of my patients are on our state's Medicaid, right? Or
Mhm.
Medicare. And to ask them to spend a few $1,000s on infusion treatments at our local infusion clinic is
Right.
outrageous and impossible. And so I wouldn't want to suggest something that they wouldn't be able to access.
I
But
spend $350 an injection or
yeah,
infusion, but now
yeah,
my doctor is able to kind of bill it for insurance. But I remember for those, I just hadn't tried the Spravato, the nose spray, but I
yeah.
remember the selling point was it's just like the infusion you have to do in the doctor's office, but the insurance will pay for it, which is
But
so
the insurance will
important.
pay for it. Yes. Yeah. So same thing, kind of like as the infusion, where my patients are under my care and recovering for at least 2 hours. They're monitored
Wow. Yeah.
in my office. But the efficacy rates, right? I think it depends on who you talk to. If you talk to ketamine clinics, they might point to one study, and there are studies out there that say like IV ketamine is the gold standard, and that's why it's worth the few $1,000s that we're going to ask you to pay
Right.
for this, right?
Right.
And IV ketamine can be awesome, but again, very expensive.
Yes.
However, if you look at all the studies broadly, there's really not a significant difference in terms of the effectiveness of S-ketamine versus IV ketamine.
That's good to know.
It's just a huge cost difference and
Right.
access difference for
Right.
patients. And some of the studies that were done, because most of them are done, with just these like real world patient trials, is we have to remember that the patients that are receiving IV ketamine are probably patients at least have means enough to where they can afford that. And we know that patients who aren't financially struggling
Right.
have better rates of their depression clearing than, say, my patients who are on state assistance or like
Right.
state run insurance, right?
I
So
just
they're
always
like
did the
when we look at the
infusion.
data,
Yeah.
right? When we look at the data, it's just I think basically what I tell patients is that there's not one that's better than the other. It's which one
Right.
is right for you in your current
Right.
circumstance.
And when I started, there was no nose spray. And I always say to people, and it is crazy how much money I do spend on my mental health, but I say there is no price tag on my sanity.
Yeah,
Like when
right,
you're feeling like you're wanting to die, yeah, I'll drop 1,000 on my credit card. Just help me feel better. You know what I
right.
mean? And I
Well,
think
yeah,
and
yeah.
unfortunately, and that's a whole nother conversation because trust me, I have fought with many insurance companies who thought I wasn't depressed enough or I hadn't tried enough treatments, which is a joke. But also I think it's important, and I can speak on this too, but talk on the nose spray. What do patients typically feel when they're getting the treatment? Like what goes down?
Yeah, so it can be a whole variety of things. Again, this is a dissociative, right? Ketamine and
Right,
esketamine psychedelic treatment. So, or psycholytic, I won't say it goes quite so far as to, say psychedelic, that like kind of lighter experience.
right,
And it can be everything from I don't think there was anything in this nose spray today because I didn't feel quote unquote anything to
right.
these very mystical and spiritual experiences.
Yes.
What we know from the research is that regardless of the experience, even for patients who come in and they don't quote unquote feel anything from the medication, that doesn't
Mean anything.
diminish the effects of the antidepressant qualities. Would I like my patients to feel more connected to
Right.
a higher power or to humanity or to themselves? Of course, I want them to have wonderful experiences. But I know that that is not a requirement for the treatment itself.
Mm,
So the overall, effect would be that they come in, we take their blood pressure, we check their O2 saturation, we kind of do our little pre-screener. We lay them down in a comfy chair. We give
right.
them an eye mask because
Yes.
having your eyes closed, ketamine is not a drug at these doses where if your eyes were open, it would be causing any visual hallucinations. But when your eyes are closed, you certainly will travel. I've had patients end up hiking in Vermont from their chair. I've had patients end up in boats surrounded by Myers lemons and powdered sugar. A
Right.
lot of patients will end up in outer space. For some reason, ketamine and esketamine seem very connected to space.
Right. I came up with the name of this podcast on an infusion, to be honest with you. I
Yeah,
literally was in
yeah.
an infusion and I
No,
thought
it's
to myself, in crisis, people make a collect call and I'm going to do a connect call. And I came out
right.
going, yes, I got the name.
That's it. I got it. Right. It's fascinating what we can experience when we're under the kind of guided and purposeful and intentional use of these types of substances for these purposes.
Right.
It's really cool. I've worked with a lot of cancer patients. These are
Mhm.
patients with that are on, palliative care, end of life.
Right.
And I've got multiple patients where they've been taking traditional antidepressants
Right.
and not seeing any benefit and going to hours and hours of therapy.
Right.
And they will come in for one S-ketamine treatment, even though usually it's a set of 12, right, that we do to start off with. And they will come out having this huge breakthrough. I
Mhm.
had a young man who was so afraid that he hadn't even told his parents and his loved ones that he was dying of cancer. He just wouldn't talk about it. He wouldn't talk about it in therapy. He wouldn't talk about it with anybody. But then after this experience, and
Right.
what he felt was this connection and kind of an understanding of what happens to us after we die, right? That happens for a lot of people,
Mm,
that it was completely transformative. He
right.
was then able to talk about it openly, accept that he was going to die, and come from a place that was really genuine. Like, this
Right.
wasn't just drugged, because the drug itself is not in our system for very long, right? So we know it's not that drugged experience by itself that is the fix. It's that
Right.
miracle grow on the brain and what happens after, in the days, the weeks, the months after we have this treatment. We just want to try and create a supportive environment to help patients with, in any way that we can, have an experience that means something more than just ingesting the drug itself.
I'm glad
Um,
you brought that up because, my mother unfortunately passed away 4 years ago from terminal cancer. And this was, she was very, growing up, very British English. They didn't take pills. It was okay if I did therapy and took pills, but my mom's like, I'm not a pill popper. And she just wouldn't do anything. And I remember her white knuckling my whole life, anxiety and depression. And when we found out she was terminal, I literally said, I can watch you physically decline. I can't watch you mentally decline. In that, for the love of God, I beg of you, let's just do a little antidepressant. But I remember at the time, I said to the doctor, I wish you guys would do an infusion with her. Like, we have nothing to lose and everything to gain. And again, we were in the UK. They're still very behind on things. But, just on my own experience with these infusions, I will say this, because when people are like, what is it like? I go, it's honestly like the best, because same thing. I'm put in this like real comfy lounger. I get a little fleece blanket and a pillow and an eye mask. I also bring my own playlist that brings me just to this. For someone like me who's nonstop in my head and just like ADHD and da da da, it slows me the fuck down, and it literally just. I sometimes go in with intention, but it just brings you to the subconscious place kind of, and many things have happened I've seen my mom in an infusion, but I'm not high. It's weird, but I think, you know, I tell people like, it's just like a really good, just like if to me, if it's meditation, if I could meditate, it just takes me to such a different calm place. The next question I am going to ask is just because I know with me, so I'll say this, I'll get an infusion at 9 a.m. and I'll start working at 12. Like, it's out of my system. I'm not driving, but I'm ready to work. You know what I mean? So it doesn't take me out for the whole day. What I have noticed it do sometimes with side effects is sometimes it'll make me hungry. It's weird. Sometimes I'll do an infusion and I'll be really tired, but sometimes it just wakes me up. But another thing that I found out about is it really, which is they ask you to use the restroom before you go because it can really kick up your bladder.
yes.
And so I've had an infusion where it was just like I kept walking to the bathroom because it was just, I felt like I just had to go all the time. So I found that really interesting. But do you know of any side effects from your patients or anything they found uncomfortable or not happy? Like, to me, there's nothing compared to a bad side effect of an antidepressant. And I don't feel any of that with the ketamine.
Yeah, and the nice thing about ketamine and S-ketamine is that the half-life is so short, right?
So short.
Any negative side effects that you will experience are going to dissipate within hours, right?
Right.
When we're talking about high dose ketamine or ketamine abuse, we know that this can cause serious problems with our bladder, right? A
Right.
long term, like really serious problems with our bladder, used in appropriate doses, like with infusions or that's ketamine in intranasal spray. It doesn't cause. We've got with S-ketamine alone, right? We are monitoring this drug so closely and the outcomes. We've got well over 6 years of data
Peace.
that prove, oh yeah, that absolutely show that there are no long-term negative effects like
No.
we see with ketamine abuse. The
Right.
cognitive effects, right? The dissociation that comes with it, right? It's expected, right? At some point that you
But
will
you
probably
like,
experience that
you're
because it's a
fine.
dissociative. Well,
Right.
and the way, yeah, and the way I kind of like to help patients who've never experienced this drug before understand it and understand dissociation is I use the following analogy. If I go to an art museum and I can look at a piece of art on the wall and it can bring me to tears, or I can look at another piece of art and it can make me feel existential terror, or another piece of art that makes me feel joy and happiness. But the feeling that is being elicited, it's not the same thing as being sucked into the painting. It's not the same thing as being depressed, right? The painting is on the wall and I'm viewing it. But when we are in a dissociative space, we're still allowed to feel things and
Right.
see things, but we have this distance between us, right?
Right.
That's what the dissociation does, right? It could just create some space. The medication itself becomes an art house curator. So even if I go into the experience with the intention that I want to look at things that just make me happy, or I just want to talk to my dad or my mom who I lost, or my brother who
Right.
I lost, right? The drug kind of decides like, no, I want you to look at this. And
Right.
I don't want to look at that. But it's like, no,
Right.
you're going to look at this, and you're going to look at this for what might feel like an eternity, even though the effects, it's really only 30 minutes. It might feel like you've been here forever,
Right.
right? And that's the effect of the medication. So for patients, in terms of the side effects, yes, that increased frequency of urination. So yeah, we ask patients not to eat anything 2 hours before
Right.
treatment or drink anything a half hour. Again, it's not because this isn't surgery. I just want them to be comfortable. And if they're in a deep state of self-exploration, I don't want
Right.
to have them get up and pee,
And that's
right?
rare that that's happened to me, like maybe
Yeah.
once or twice in all my years. And I just have to say, your analogy with this is why I adore you, because you do these like, I just wish you taught everything. Like, you really need to do your own podcast too,
Yeah.
because you really just break this down for people like me, where I'm like, oh my God, I totally get that. And I'll
Yeah.
use that analogy.
I'll use that analogy. Yeah. Yeah. Feel free. It's yours.
Yeah.
And so where it can be really difficult, those side effects of dissociation, where I'm really doing a lot of exploration, prior to treatment to make sure it's the right treatment for somebody,
Right.
is somebody who where having that drugged feeling or being dissociated
Right.
is going to affect them negatively. And so,
Right.
for example, in the research that was done prior to the medications being used in market, there didn't seem to be any response difference between patients who had what's called borderline personality disorder and might have dissociation from that itself.
Right.
But in practice, that is a patient population you need to be very cautious of, because there can be some potential negative effects for that population with the use of this medication.
Can I ask on that? So part of, my journey in helping people, I've helped, some families and some children who have survived school shootings. And I was
Hmm.
working with this one child who is still in my life, and I adore her, who was telling me she survived Parkland. And she was in one of the classrooms where a lot of 3 to 4 kids, I think, were killed in front of her. And one of the treatments they tried for the PTSD was she went to Yale to do a trial with treating her PTSD with the ketamine. For her, it wasn't effective. But what was the goal in that?
Yeah.
You talk anything on that? Because that was interesting to me with treating PTSD.
Yeah, so psychedelics in general, there's been a big interest in treating PTSD, right? If we think about the MDMA trials, we
Right,
think about the use of psilocybin
right,
now being used in treatment centers in Oregon and Colorado, for example.
which is awesome.
So psychedelics, I think, kind of as a blanket, right, can help with trauma. And I've certainly seen ketamine and ketamine help with trauma with my patients, and even patients who it becomes like a therapy booster, right? So
Mm,
again, that glutamate burst, right? That
right,
miracle grow on the brain. What I explain to patients, it's not the drug itself that is the fix, because if it were, and I had to be on a steady bloodstream of ketamine in order for this to be effective every day of my life, this wouldn't be realistic treatment. It's
right.
getting the medicine in so it can help that glutamate burst, letting the medicine go, and then understanding what to do with that miracle grow. So if I've got miracle grow on a garden it doesn't matter if I didn't plant the right seeds or if I don't tend to my garden. So for patients who are having struggles with maybe traditional EMDR treatments or treatments for, therapy treatments, talk therapy treatments for
PTSD.
things
Yeah.
like PTSD, these medications can really help them break through. And I've seen that multiple,
Right.
like I have multiple examples of,
And I think
thousands of treatments that
that's
I've
something
done
we
and
haven't
seen
really
that help.
talked about. Sorry, but
Yeah,
it
no,
is something people have done, and was part of it too. We call it cap therapy, where where basically you're doing the infusion, you're going to this place subconsciously, and there's a therapist in the room who is interacting with you to kind of, like you said, like all those other traditional treatments didn't take that wall down, and so
correct.
it allows
Or
you.
it's didn't take that wall down because these are walls that we build up to protect ourselves, right?
Right,
Jungian psychology, we have this idea of like what's called the shadow self, like things about my life or my experiences that I push off into the shadows that I don't want to bring light to because I have to function. I have to go to work. I have to be a partner.
right,
I have to go to school. I kind of have to get through. And so I don't want to think or bring this out of the shadows. I just want to stick this. When we take these medicines back to that art house curator, oftentimes they will just come right out into the light. And so again, for my patients who have done CAP types of therapies, it's amazing what they will share. And again, this
totally.
isn't like you're in like blackout drunk and like, oh, I can't believe I said that. I can't remember. It's not that
Right,
experience whatsoever. It's by allowing that safe dissociation between the memory and the emotional experience.
right.
I can now emote and talk about these things, but in a way that feels a lot safer. And
Yeah,
it is genuine. It is not oh, I'm just said that because I was intoxicated. It's nothing
right,
like that. So
right.
for a patient like you were describing, it makes sense that they would try something like this if other treatments had shown
Had
to
not
be
worked.
ineffective, had not
Right.
worked. Right.
So I also part of why I do this podcast is at the end, obviously, I'm going to be leaving information about Jonathan Lowe, J. Lo. So, if you are in the state of California, right, because you're licensed just in California or anywhere else,
California, Nevada,
in Nevada, you
Nevada as
can
well.
utilize his services. But also, I guess what I want to leave people with is like, how do people access or even get assessed for the nose spray or the infusion? Like, what steps do people need to take who are like, I want to do this. I want to try this. This, might be good for me.
So the Spravato website you'll be able to type in, your location, where you're looking for providers,
And we'll have
and
that in
then
the notes
and
part.
we'll have okay,
Yeah.
perfect. And they'll just have like a list of here are all the providers in your area that are using Spravato. Now those services, again, the assessment itself and the treatment will be covered by insurance if you meet clinical criteria. As far as ketamine clinics go, I mean, they're kind of everywhere now.
Yeah, they
It's
are.
hard for me to, but again, when it comes to access, right, it's just about cost. And then, like you mentioned, there are online providers. An example would be like, say, like MindBloom, right?
Yeah.
It's a famous online provider where insurance will often cover the evaluation, sitting down,
Right.
talking with a licensed clinician to see if you meet criteria. But then
Right.
the medication itself not being FDA approved, there will be a cost to it,
Right.
cash
Right.
cost. And that's until these newer medicines are FDA approved. And again, a really good, to give you a good idea about where psychiatry is heading with the treatment of multiple disorders. I know we've been focused on depression for addiction, OCD, trauma, anxiety, all sorts of things, is that you can go to a website called
Yeah.
psychedelicalpha.com and they have a bullseye chart. And they
Ooh.
have an updated bullseye chart that shows you what stages all of these different psychiatric drugs that are being studied are in and how close they are to like full FDA approval. And it's remarkable what
Wow.
is being studied out there and what is coming down the road
Right.
that might be, really helpful for patients. I know we couldn't get into even like half of what we could talk about today. But again, from personal
We
experience
technically only really
and
have 45 minutes, and we've totally gone over. But here's the
oh
cool
my
thing,
God, we
Jonathan,
only
I'm
have
totally
45
bringing
minutes.
you back on this podcast.
Oh, we should, because then we could dive more into the addiction piece. Because
Everything.
I can tell you, in terms of treating folks who struggle with addiction, in my experience and in the studies, what we see is oftentimes this is what's happening is that I have patients who are coming in who have been relying on other substances to get by with their symptoms. And once they start these treatments, they stop using other substances.
Amazing.
And it's remarkable how fast and how naturally they will
Right.
just decrease. And we've seen this across the board since the 1960s with psychedelic treatments in terms of their potential to really help rewire
Right.
the brain and the dysfunctions in the brain
Right.
that happen with things like addictive disorders.
And I'm so glad you're talking about this and we're saying this, because there are so many people still in the addiction world who are
Yeah.
like, we need to do more, sessions and talks about how these psychedelics are addictive. And I'm like, yo, get with the program. And the way I feel and what I'm excited, because as someone who has struggled for years and who had been resistant to the traditional antidepressant, let's say, it is exciting that there are options out there now today and that can really, really, really help people and rapidly, and I think
And that's the key,
that's
right?
the key. It's rapid. And the way I'm looking at it is, for those who are anti whatever, I'm like, get on the train. This is kind of like how people were back in the day with the antidepressants. And we're like, I don't know about that.
Yeah, and I get it,
Psychedelics
right?
and all of this are going to be part of the norm. And I love that.
They will be part of the norm. I think that the next, at least couple of decades in psychiatry, if everything goes the way it has been going, we're going to be
Right.
focused on psychedelics and electricity in terms of really how to better treat patients.
Right.
Like, it's all going to be like, this is an electrochemical organ, right?
Right.
And we're going to be focused just because of the outcomes of what we're seeing and the research. And I keep little stickers of Bill in the fourth dimension, for my folks that are in recovery that are nervous about these treatments.
Right.
And we just talk about how psychedelics are nothing new to the recovery community, and in fact have been helping a lot of people, including some of the founders of recovery as we know it,
Yeah. Thank you.
reach a space where they feel much better. And again, it's about working with the right person. I don't want to say like, hey, this is great and it's
For
all
everybody.
safe. It's not, right? Absolutely, like, all these things have their potential downsides,
But for people like me, there's always been this shame, like I'll go to
right,
a meeting tonight and I'm not going to share on this, you know what I mean?
right.
Because I feel like,
Whereas, yeah, like
and
alternative groups like psychedelics in recovery, where
right,
you have that population that understands, like, okay, we kind of see where this is going and how this has been helpful, and this isn't
right.
anything new.
Nope.
It's just that what is old is new again because of the stop in research for these medications.
The way I look at it also is like, if I go in for surgery and my doctor, prescribes me a week of Percocet, I take as prescribed. It's no different than me being prescribed a psychedelic. And people like yourself, there's other people in the industry I know that are coming back around and they're starting clinics as well. And it's just exciting stuff, because anything that we can help more people with, who are we to judge, And I always say, step into my shoes, when you want to die, like I was like, tell me what to do. I will also say this, because I'll always say these on these episodes. There is no magic pill. There is no magic shot. There's no magic injection, no spray. You have to do a bunch of other things. You have to do,
Yes.
Go to the gym. You have to eat well, like do all those DBT skills, all of that. It's a whole mixed bag. But what these new treatments are not new treatments. What these treatments are helping us do is being able to do those things, for
Right,
someone
to
like
actually
me.
do those things.
Yeah.
1000%, where the depression, that dark dog of depression is preventing us from waking up and being able to make that breakfast, or to
Right.
go and exercise, or just
Right.
just to engage with the world.
Right.
But yeah, you still have to engage with the world in order for
Right.
these treatments to work.
because we have to wrap up, I want to say thank you. I also am already
Yeah,
asking you to come back on the show because I think
I'd
you're
love to,
a
because
wealth of knowledge.
we only talked about maybe 10% of what I would like to talk about. So this is great.
Next show is on you, like whatever you want to talk about. And, in the notes, we're going to be leaving, again, some of these websites we talked about, some of the notes that we talked about, bullet points on like facts versus fiction, and also J-Lo's information, Jonathan Lowe, just because he is one of the best out there.
One of the best. Oh, thanks.
But thank you for being on the show, and can't wait to see you again.
It's a pleasure. Thank you so much for having me.
Thank you for tuning into this episode of Connect Call. As we conclude, remember that insights shared are intended for informational and educational purposes only and should not substitute professional medical advice, diagnosis, or treatment. We strongly recommend consulting a qualified medical health professional or healthcare provider for personalized advice tailored to your unique needs. Your mental health journey is important, and having the right support is essential. If you're experiencing a mental health crisis or require immediate assistance, please reach out to a mental health provider or emergency services in your area. We're grateful to have you as part of our community, and your well-being remains our priority. So follow us on social media to stay connected, and be sure to catch one of our episodes on our YouTube channel. We're here to support you every step of the way.